Very important topic that is called as neonatal resuscitation. So the neonatal resuscitation, different steps are followed and we have to go in this particular format itself. So the first is the initial assessment. So initial assessment is done of both the maternal history is taken into consideration as well as the fetal conditions. For example, whether was it a high risk pregnancy or there is intrauterine infections associated with it, was there a prolonged labor or the preterm delivery, amniotic fluid. So these all things are taken into consideration during the initial assessment. Then, if the baby does not cry, after birth, then the initial action is taken. The important system that is maintained is the respiratory system. So that means the airway and breathing needs to be maintained. After that, the newborn babies are always prone to hypothermia. So we always give warmness. To maintain the airway, we have posture. So slight extension of the neck is important, and that position is called a sniffing position. How can the sniffing position be attained? The sniffing position can be attained by using pillows below the shoulder or any other cloth below the shoulder of the child, so that there will be slight extension of the neck. Then you can stimulate the breathing by rubbing on the back of the baby or by flicking the sole of the baby. Now, even after these things, the baby does not cry. Then we need to assess the heart rate and the respiratory effort. So, if the heart rate is found out to be more than 100 and the baby has got a good respiratory effort, so in this particular condition, we are going to maintain an oxygen hood so that oxygen is provided to the baby. In case of preterm neonates, we go for CPAP, that is continuous positive airway pressure. But if the heart rate is found to be less than 100 and respiratory efforts are present, so in this particular case, we go for positive pressure ventilation, that is PPV. So positive pressure ventilation, it is done by two techniques, either a non-invasive and invasive technique. So if the non-invasive technique fails, then we go for invasive technique. Non-invasive technique consists of bag and mask ventilation, while the invasive technique consists of endotracheal tube intubation. Now, important over here is, in the bag and mask ventilation, there is a mask that is going to cover both the nose as well as the mouth of the baby. It should be adequately covering the nose and mouth. It should be properly positioned. The position of the baby should also be proper. Then, what should be the rate at which we are going to so the rate is 40 to 60 per minute. The pressure that is applied, that is different. So the first pressure that is applied, it is about 20 to 30 centimeters of water. It is because the alveoli are collapsed. So to open the alveoli, to distend the alveoli, 20 to 30 centimeters of water is the first pressure. The subsequent pressure, it is half of it, that is about 15 to 20 is applied. Then what is the levels of fractional inhaled oxygen that is going to be supplied? So in case of neonates that are over 35 weeks or up to 35 weeks of gestation, in those neonates we are going to give a room air by the ambu bag. But if it's a neonate of less than 35 weeks, then in that case the FiO2 of 21 to 30% is given. If we connect oxygen delivery system as well as the reservoir bag to the bag and mask ventilation, that is that mask, then we can even give up to 90 to 100% oxygen, but we don't provide it because it can lead to hyperoxia and it can lead to retinopathy of prematurity, which can lead to blindness in the baby. Talking about if the bag and mask ventilation fails, then we can go for endotracheal tube intubation. So laryngoscope is used. The blade of the laryngoscope used over here is not curved, it is straight in case of neonates or infants. The size, it comes in two sizes, 0 and 1. So 0 is used in preterm neonates and 1 is used in term neonates. The inner diameter, it varies. The inner diameter is if the weight of the baby is less than 1 kg, if the weight of the baby is 1 to 2 kg, and if the weight of the baby is more than 2 kg. On the basis of age also, if the age is less than 28 weeks of gestation, if it is 28 to 34 weeks of gestation, if it is more than 34 weeks of gestation, then the inner diameter of the laryngoscope, that is, or the endotracheal tube that is used, that is, here it is 2 millimeters, here it is about 2.5 millimeters, and here we go up to 3 millimeters in diameter. Now, very important thing over here is targeted saturated partial pressure of oxygen levels. So after 1 minute, it is 60 to 65% should be the SpO2 levels, because we are going to continuously monitor the pulse ox. Then in 2 minutes, just add by 5%, so it is 65 to 70. In 3 minutes is 70 to 75, then 75 to 80, then 80 to 85 at the end of 5 minutes, and then at the end of 10 minutes it should come to normal, that is 85 to 95%. So this is how the levels of oxygen they are maintained by positive pressure ventilation. But if still the heart rate remains to be less than 60, then in that case we need to go for chest compression with ventilation. What is the ratio? The ratio is 3:1. So if we talk about in a minute, there should be 90 compressions and 30 ventilations. What is the method? We used mostly the 2-thumb method because it is less fatigable, and the depth of pressing it should be 1/3 of the anterior posterior length. Then if still it's not still the heart rate needs to be low, then adrenaline is given. The route of adrenaline, it is IV, that is intravenous in the umbilical vein. Then the dose is about 0.2 ml per kg, and the concentration is 1:10,000. So this is very important. Or 0.1 ml per kg can be given, 3 doses can be given. Now very important over here is what is golden minute. Golden minute is that right from the initial assessment to the start of the positive pressure ventilation, it should be decided within 1 minute. So that is considered to be the golden minute for neonatal resuscitation. The total duration for neonatal resuscitation is 20 minutes. If still after 20 minutes the heart rate remains to be low, then it's very difficult. Then there are certain conditions where neonatal resuscitation is of no use. For example, in anencephaly or trisomy 13, that is Patau syndrome, Edwards syndrome. So in those particular cases, the neonatal resuscitation is of no use. Most sensitive and the first indicator of resuscitation. The most sensitive and first indicator of resuscitation is the increase in heart rate. Very important. This is the MCQ. And the baby, if the baby is born through a meconium stained liquor, then in that particular case also we go for the same, that is the endotracheal tube intubation along with suction. So very important is something called a suction as well. The suction, it can be done during the time of initial action. What happens is that we need to clear the airway, and airway is cleared by suction, and suction should be always done in the mouth first and then in the nose. Then if the baby is born through MSL, then it is classified into two, vigorous babies and non-vigorous babies. It's earlier classification, now it is reformed, but still they ask what is vigorous babies. So we can remember it by HRT. So vigorous babies are those where the heart rate is more than 100, the respiratory efforts is good, and the tone of those babies is also good. So in those babies, neonatal resuscitation is also given. So this is all about the neonatal resuscitation in neonatology.